Part 4. When we administer medications, as you know, there are a variety of methods. So when we're giving injections, things to keep in mind. Give an explanation that is developmentally appropriate for the child. How long is it going to last? What will they feel? Now, your book says that we can prep by the injection site by applying ice. I've never done that. I fear that we're going to cause a burn. But what we do use is a topical anesthetic. And one example is EMLA. But what you have to keep in mind is this needs to be applied within 30 to 60 minutes of the time of injection in order for it to work. So what you do is you put a large blob of medication on the area where you're going to inject. And then we seal it over with a Tegaderm or Opsite type of a dressing. You don't want to use gauze because it's just going to absorb all of this cream into it and it's not going to be effective. What this is going to do is it's going to penetrate through the dermal layers so that the child will not feel the needle go through the skin. They will still feel the medication as you inject it, so expect that. We need to have the child cooperate as much as possible, and you are definitely going to need parental assistance in helping to hold the child. Sometimes parents will say to a child that if you're not good, the nurse is going to give you a shot. I cringe when I hear this, as you should, and you want to correct them immediately because you don't want to be known as the bad guy. Use therapeutic communication and talk to the parents and the child and say, no, that's not true. We only give you a shot when you need to have it because you're either sick or to help you from getting sick. Make sure that you use the correct needle size based on their age and development. And there is a table that's in your book, and you do need to know that because I don't want you going into with a 2-inch needle and you're going to give an IM injection to a neonate. Do keep in mind that when we get injections, it hurts, they feel threatened, and it's a stressful situation for the child. The most common injectable meds we give are one-dose antibiotics, so you'll be doing this in a clinic, in the emergency room type setting. Immunizations are definitely given IM. Always select the appropriate site. The vastus lateralis is used for infants and toddlers. And then just review the ventrogluteal, the dorsogluteal. We very rarely actually administer meds here. For the older child, then we will use the deltoid, and remember the rule of 2 finger widths below the acromion process, and then pinch up the muscle a little bit and then inject. So the needle size, we go from a gauge of 21 to 25. And you want to make sure that the volume that's in your syringe is safe. And if it's too much, then we may have to give 2 injections. So look in your textbook because it depends on the age of the child on what the full volume is. The maximum volume for a subcutaneous injection is 0.5 ml. And the needle insertion for a sub-Q can be at the 45-degree angle or 90-degree angle if you pinch the skin up. Every once in a while, we'll be giving a rectal medication, primarily antiemetics or Tylenol suppositories. And we're going to give this if the child can't take the medication orally. Do keep in mind that this is intrusive, stressful, and uncomfortable. You need to use a lot of lubricant. Explain the medication and how often it is going to be given and why. And tell them not to bear down or expel it after it's given, because if they expel it immediately, it's never going to be absorbed. So position the child on their side and the upper leg is flexed. Have them take a deep breath and just tell them to bear down like they're going to go poop. And then you're going to slip it in. You've got to get your finger in through that sphincter, and they will probably end up squeezing on your finger with the sphincter. That's great. And tell them to just keep it there. You want to go 1 to 2 centimeters into the rectum, and then as you take your finger out, you want to squeeze the buttocks a little bit, and that helps decrease the urge for them to immediately expel it. When we give an otic medication, it's a clean, not sterile technique. If we can keep the medication warm at room temperature, it decreases the amount of pain on a sensitive, inflamed ear. Check the canal for debris. Cleanse anything out that may obstruct with the medication. But you may see what we call a wick that's placed into the canal. Don't take that out. What you're supposed to do is put the medication on that wick, and it will suck up the medication. It's some type of a cotton fiber, and it'll take it down into the canal. So have them laying down on their side, and in the older child, you're going to pull the pinna up and back, but in a 3-year-old and under child, you're going to pull the pinna down and back in order to straighten the canal for the fluid to flow in. You need to know that. Insert the drops, and you have to count 1, 2, 3, or 4, whatever they say, and then you want to massage the tragus so that the medication stays in. If possible, we want them to rest on that side for a minute so that it doesn't immediately come out. But trust me, your toddlers, they're not going to sit there for a minute. So you just keep them down as long as they can. And we have to go on the other side many times also. So try and wait a minute and then turn them and do the other side. Only insert cotton balls if the physician or nurse practitioner has ordered it. Ophthalmic medication is also clean and not sterile, and it comes in the form of drops or an ointment. If the patient needs both, you want to put the drops in first and then the ointment. If you do it the other way, those drops are going to bounce off the ointment and it's not going to be used at all. Remove any exudate prior to administering medication. You can do this just with a warm, moist cloth. Hold the head and still between the lid and the eyeball in the older child. Have them look up and then put the drop. For the younger child, you're actually going to have to restrain their head and arms. And sometimes what I'll do is I'll just put their arms up over their head, and that helps keep their head in place. And then I put the drop on the inner canthus. When they open up their eye, the medication goes in. We can consider mummy wrapping them if we have to, but it's not the best. So you do need to pull down on the conjunctiva. That's the actual correct way to do it, is pull down on the lower lid so that you can see the conjunctiva, and then you place your drop or ointment. Keep the eyes closed for a minute so that it can be distributed throughout the eye. And avoid contaminating the tip of your dropper or the tube by touching the eye or the skin. So use your fingers to keep yourself away enough so that you can just drop it. Be about probably an inch away from the eye or half an inch, and you should be able to get even ointment into the eye. For the nasal, we're going to be giving saline, antihistamines, and you can just read through this slide on how to do that. You want them to not blow the nose immediately after. Just give them a Kleenex to blot anything that might drip out. For topical, it's usually for a localized treatment of some type of a rash. Clean the skin, place the medication amount on a gauze, and then apply with gloves. Cover only if the physician orders it to be covered, okay? Now, topical meds are one of those that they don't really say exactly how much you have to give. So like I said in an earlier slide, just put a pea-sized amount on gauze or on the tip of your finger, lightly blot the whole area, and then use another finger to distribute it. And if you need more medication, you still have some on your pointer finger. And then we have our inhaled route. Most of the time, respiratory therapy is going to be administering these, but there are going to be times where respiratory is really busy and it's going to be you. We're going to practice this in Skills Lab, but we have a variety of masks and devices that we can use to give nebulized medications. For metered dose inhalers, we almost always use a spacer because we get better delivery. It's very portable, but it is difficult to use for a small child because they don't really understand that they need to be breathing, taking in that deep breath. So we're primarily going to nebulize medications for the small child. So this ends part 4. Move on to part 5.